Dear audience, dear chair, I would like to present my PhD topic, which is optimizing the nutrition of critically ill children by timing and dosing. My name is Andrea Lábodi, and I am a pediatrician in Bács-Kiskun Hospital in Kecskemét, and I am also a first-year PhD student in Semmelweis University. As a pediatrician, I started to be interested in intensive care, and this is how I realized how important is the nutritional therapy of this population. This is how my vision started, which is provide adequate nutrition for critically ill children to improve survival. And related to this vision, my mission is investigate the optimal nutritional therapy of critically ill children for better outcome. Related to this vision and mission, I have two specific goals. Both are about the optimal nutritional therapy of critically ill children. The first about the optimal protein intake, and the second is about the optimal timing of parenteral nutrition. So about my first project, which is investigating the effect of higher levels of protein intake on mortality and recovery of critically ill children, and it's a systematic review and meta-analysis. The nutritional therapy is a crucial part of the management of critically ill children in the pediatric intensive care unit. And in this therapy, the protein is one of the most important substrates. Inadequate protein intake can increase mortality and prolong in-hospital days. Several studies showed that earlier. The minimum recommended protein intake, 1.5 grams per kilogram per day, to avoid a cumulative protein deficit, but the optimal intake is likely to be higher, but unknown. Our aim is to determine the optimal protein intake for critically ill children. Our clinical question is what is the optimal dose of protein intake to reduce mortality and morbidity in critically ill children. We use the PICO framework. The population are the children in the pediatric intensive care unit, the intervention and the comparator, the different levels of protein intake. The first outcome are clinical outcomes, such as mortality, length of stay in the pediatric intensive care unit and in the hospital. And the second outcomes are nutritional outcomes, such as nitrogen balance, proalbumin, and retinol binding protein levels. Our hypothesis is 2 to 4 grams per kilogram per day. Protein intake provides the best survival and shortest stay in the pediatric intensive care unit. And the clinical implication would be accelerate recovery through optimized nutrition. This is the finalized search key. The first domain is about the population, which is the pediatric population. The second is about the critical illness and the postoperative period. And the third is about the protein intake and the fortification of the nutrition. We conducted our search in 3 databases, and these are the numbers. We had almost 10,000 results, and we ended up with 45 eligible full text, and in the citation chaser, 4 more full text. We have ongoing analysis, the nitrogen balance, the length of stay in the pediatric intensive care unit, in the hospital, the mortality, the proalbumin, and retinol binding protein levels. This is my progress. We currently finished the data extraction, and we would like to move on the risk of bias assessment. And now I would like to speak about my second project, which is investigating the optimal timing of parenteral nutrition on mortality and recovery of critically ill children, and it's a randomized controlled trial. As I mentioned earlier, the nutrition therapy is a crucial part of the management of critically ill children, and in this therapy, the early enteral nutrition is the preferred choice. But not all critically ill patients can receive enteral nutrition, and in this case, parenteral nutrition is needed. The optimal timing and dosing of parenteral nutrition is unknown, and it's related to the phases of the critical illness. As you can see in the picture, we can speak about an acute phase, and in the acute phase, early and the late acute phase, and after that, a post-acute or a stable phase. Usually we can say that the early acute phase is the first 4 days of the critical illness, and after that, the late acute phase, 4 to 7 days. And every phase is, different nutrition is needed in every phases. Recent guidelines suggest that the parenteral lipid and amino acid intake should be delayed until 1 week. But it's a recommendation based on one singular CT, which compared only day 1 and day 7. They started day 1 or day 7, the parenteral nutrition. And there is a smaller contradictory study too. So there is not enough evidence on the benefits of starting parenteral nutrition earlier or later. Our aim is to determine the optimal timing of parenteral nutrition for critically ill children. So our clinical question is, does starting parenteral nutrition on day 4, which is late acute phase, change the mortality and recovery in critically ill children? We use the PICO framework, the population children in the pediatric intensive care unit with inadequate enteral nutrition. The intervention would be starting parenteral nutrition on day 4, which is the late acute phase. The comparator is the starting parenteral nutrition on day 7, which is stable phase, which is the recommendation now. And the first outcome would be the length of stay in the pediatric intensive care unit. Others are mortality, days on mechanical ventilation, in hospital days. Our hypothesis is starting parenteral nutrition on day 4 is clinically superior to withhold it for 1 week. And the clinical implication is accelerate recovery through optimized nutrition. We are in the protocol drafting phase. We have some inclusion and exclusion criteria. In the inclusion criteria, we would like to include critically ill children in the pediatric intensive care unit with inadequate enteral nutrition on day 4, which means that they can reach the 80% of the targeted calorie. And exclusion criteria would be inborn metabolic diseases, diabetes mellitus, condition which require the parenteral nutrition before the admission in the pediatric intensive care unit, premature newborns, and severe malnutrition and dialysis. As I mentioned, we will have to start the parenteral amino acid and lipid on day 4 or in the day 7. The primary outcome is the length of stay in the pediatric intensive care unit. Secondary are other clinical outcomes. Summary, I would like to say that I have 2 ongoing projects. The first is about the optimal protein intake. I would like to finish this autumn, and the other is about the optimal timing of parenteral nutrition, which I would like to finish at 2026 in November. And I would like to finish a quote from Albert Einstein: "The important thing is not to stop questioning. Curiosity has its own reason for existing." Thank you for your kind attention.
Regarding your second topic, why did you choose day 4?
Because usually it's the start of the late acute phase, and in the early acute phase, it can be harmful to give too much protein and lipid, especially in parenteral way. But the previous study didn't examine that is it maybe beneficial to start a little bit earlier than the stable phase, which is the late acute phase. And in children, they need lots of nutrition normally too, not just in a critical illness. And critical illness, it's higher they need. So this is why we think that it's beneficial not to withhold so long.
And by children, you mean everything under the age of 18, or do you think there is also a difference in younger children, middle-aged children, older children?
If we will have enough patients, we would like to do subgroup analysis in this because the infants and toddlers and older children are different in this nutritional therapy, but we would like to include all the children.
What do you think? Why can it be beneficial to withhold parenteral nutrition?
There are some theories for this, not an exact answer, but maybe in the early acute phase, too much protein and lipid and energy can be harmful because withhold it can preserve the autophagy, for example, which is an important part of the immune system, and other immune pathways have so in the immune pathways has an effect the too much nutrition.
Will you include all ICU patients, or there will be an exclusion criteria?
In the first project?
Yes.
Thank you for your question. Yes, we have some exclusion criteria, which so the premature newborns, because they have very different nutritional strategies, and patient on dialysis, on ECMO, because they have other recommendation for the nutrition.
I understood that, okay, the higher protein intake can lead to better patient-related outcomes. But do you also take into considerations, for example, the components of the protein, so for example, the amino acids?
Thank you for your question. It's a very interesting question, and it would be, I think it would be a good RCT in the future to examine the different different amino acids because they have different effect. There are very little study that examined, for example, glutamine, but not enough for meta-analysis.
So as a follow-up question, beside the amino acid types, is there any other subgroup analysis that you might consider for your first project?
Yes, if we have enough data, we would like to do the same as I mentioned in the second project, the age groups, so infants, toddlers, and older patients. And the other is the postoperative patient and other critical illnesses such as sepsis. And
okay, thank you.